with dysautonomia. But what exactly does that mean, and how would you know? So this lecture will be kind of an introduction to the area of dysautonomias. Before I go too far, I want to let you know that everything I'm going to be talking about is already in a book that I wrote, which is free, and it's called Principles of Autonomic Medicine. It's about 700 pages long and has about 400 illustrations, and the way you can get to it is by looking for me on my NINDS webpage. I wrote this as an official duty activity. If you Google me, what you're looking for is this picture of me where I've got this white beard, not the one where I'm younger, but this one. And then you'll go to selected publications, and when you're there, you'll see this. And then you click on download, and you should be able to download the book as a large PDF. Or from PowerPoint, so that are on my, and I hope okay. And now the talk. A very general definition of this to a condition where altered activity of one part of the autonomic nervous system adversely affects health. According to this definition, the most common abnormality, the most common autonomia, would be one where normal changes in autonomic function are harmful because it's in the setting of independent pathologic. An example would be the old man shoveling snow. Stop talking now, so that's what I'll do.
Hi. There was a technical glitch, so I'm talking into my phone. This is about what dysautonomias are. I hope you've already gotten the information about how to get to the Principles of Autonomic Medicine book. And we'll start with the PowerPoint slides in this lecture. One second. In dysautonomias, there's altered activity of one or more components of the autonomic nervous system, and this altered activity adversely affects health. The most common condition is one where normal responses of the autonomic nervous system worsen an independent pathologic state. A classic example would be the old man who suffers a myocardial infarction while shoveling snow. The idea is that in the setting of an independent pathologic state, the coronary artery disease, a normal increase in sympathetic, noradrenergic, and adrenergic function. One second. A normal change in autonomic function will precipitate the heart attack, the myocardial infarction, because of the increase in myocardial oxygen consumption in the setting of coronary artery disease. But for the rest of this talk, I'm going to be largely considering changes in autonomic function that are due to some problem with the functioning of the autonomic nervous system. I think of dysautonomias in terms of a whole universe of conditions that can be divided up in terms of pediatric, adult, and geriatric. Pediatric diseases, as you see, include things like familial dysautonomia, Menkes disease, and so forth, PKU. There's a large group of kind of overlapping syndromes in adults where the problem is not one of development of the autonomic nervous system so much as some problem with functioning. And then finally, autonomic failure can occur in the geriatric population because of an actual degenerative loss of autonomic innervation. And by and large, the diseases that you're considering would fall into the adult category, and they also overlap. Chronic fatigue syndrome, postural tachycardia syndrome, or POTS, syncope, arterial barrel reflux failure, and an interesting condition called pseudo-pheochromocytoma, where the patients seem to have pheochromocytoma, a tumor that makes catecholamines, because of episodes of paroxysmal hypertension, but they actually don't have a pheo. All of these conditions involve chronic fatigue. Now, why are dysautonomias so hard? And they are hard. And I can think of a few answers to this question. First, dysautonomias are multidisciplinary. A patient could consult with a cardiologist because of a heart rhythm or rate problem or hypertension, could consult with a neurologist because of seizures or Chiari malformation. Could consult with an endocrinologist because of thyroid problems or adrenal problems. Could have a GI complaint, psychiatric issues, chronic pain, and so forth. And this reflects the fact that dysautonomias typically are multidisciplinary, and there isn't any discipline of autonomic medicine. So the patients can kind of fall through the cracks because there isn't any specialty or specialist where the clinicians are competent at and comfortable with evaluating the patients. So one reason dysautonomias are hard is because they're multidisciplinary. Second, dysautonomias are complex. This diagram is designed to show the multiple interacting loops for regulation of blood pressure over here. It involves at least two types of information to the brain. It involves at least 6 effector systems. So it's very difficult to pinpoint an abnormality when a patient has a problem with blood pressure regulation. Another reason that dysautonomias are hard is because they're essentially mind-body disorders. The traditional separation of mind and body, this doesn't work in terms of diagnosing and managing the patients. Instead, things look more like this. The autonomic nervous system and somatic nervous system are closely linked, and both affect the inner world inside the body and the outer world, how the body is interacting with the outer world. So this is another reason that dysautonomias are hard. You can't figure out what's mind and what's body. Another reason that dysautonomias are hard is because there's a large group of autonomic function tests. We'll go over a few of them, but this list is only partial. And different centers emphasize different tests. None of these tests alone assesses all of the components of the autonomic nervous system. So you have to understand which test is for what purpose. That means that another reason that dysautonomias are hard is because of the array of tests that could be done. Now we'll get a little bit into what the autonomic nervous system is. I think of the autonomic nervous system as the part of the peripheral nervous system that deals with the automatic, unconscious, involuntary events that occur in the inner world inside the body. This is in distinction from the voluntary, conscious behaviors that are mediated by the somatic nervous system and are mediated by skeletal muscle. The phrase autonomic nervous system was coined by the English physiologist Langley, and it was based on his perception of ganglia. These were accumulations of nerve cells arranged kind of like pearls on a necklace on each side of the spinal column. Langley thought that the nerves coming from these ganglia functioned independently of the central nervous system. And one of the reasons that the phrase autonomic was used. Well, it's not true, but that is the origin of the phrase. To kind of convey what the ganglia do, I'd like to use the analogy of how electricity gets to your house. You have a generator plant and these large trunk lines that come to a utility pole outside your house. And there's a transformer there, and coming from the transformer, there's thin wires that actually go to your house. And analogously, there are thick, myelinated, rapidly conducting fibers that go from the spinal cord to the ganglia. But there are thin, slow-conducting, non-myelinated fibers in general that go to the nerve terminals. So the ganglia are analogous to the transformer boxes on the utility pole outside your house. Langley thought that the autonomic nervous system has parts. There are three parts that he described. Enteric nervous system, referring to the autonomic nerves in the walls of the gut. Parasympathetic nervous system, which is another phrase that Langley invented, and sympathetic nervous system. Sympathetic nervous system is not a phrase that Langley invented, and it goes back to the teachings of Galen, the 2nd century Greek physician whose ideas dominated medical thought and practice for about 14 centuries until Harvey's description of the circulation of the blood. Galen taught that the nerves the nerves are responsible for distribution of the animal spirits in the body, and because of these hollow conduits, the organs of the body would work in harmony with each other, in concert with each other, in sympathy with each other. So this idea of the sympathetic nervous system somehow coordinating the functions of multiple body organs is ancient and probably essentially correct. In the early 20th century, the great American physiologist Walter Cannon added a hormonal component to the autonomic nervous system. This was the adrenal medulla. And Cannon thought that the sympathetic nervous system and the adrenal medulla work together as an emergency system to maintain homeostasis, a word that he coined in emergencies. This idea of a unitary sympathico-adrenal system persists to this day. As we'll see later on, this idea is not quite correct, but it's still widely held. From now on in this talk, SNS will refer to sympathetic noradrenergic system, for reasons I'll explain shortly, and SAS, sympathetic adrenergic system. Cannon became so convinced that these two components work together that in the 1930s he formally proposed that the chemical messenger of the sympathetic nervous system is the same as the chemical messenger of the adrenal medulla, namely adrenaline. He called it adrenin. And he was wrong. And this probably cost him a Nobel Prize, because in the 1940s, a Swedish physiologist named von Euler correctly identified the chemical messenger of the sympathetic nervous system as norepinephrine or noradrenaline. And for this discovery, von Euler shared a Nobel Prize in 1970. Approximately in the 1930s, 1920s, Dale introduced what can be considered a fifth component of the autonomic nervous system, the sympathetic cholinergic system. This is responsible for sweating, gustatory sweating, thermoregulatory sweating, emotional sweating. So now you can see that there are three components of the sympathetic nervous system depending on the chemical messenger. The chemical messenger for the parasympathetic nervous system and for the sympathetic cholinergic system is acetylcholine. Adrenaline or epinephrine is the chemical messenger of the sympathetic adrenergic system, and norepinephrine is the chemical messenger of the sympathetic noradrenergic system. The enteric nervous system involves so many different putative neurotransmitters or chemical messengers that nobody really knows exactly how they're arranged. This is kind of an overview of the distribution of autonomic nerves in the body. Parasympathetic innervation is thought to be from cranial nerves, such as the vagus nerve, and pelvic nerves. The sympathetic nerves come from the thoracolumbar spinal cord. The parasympathetic nerves are mainly myelinated, rapidly conducting, and there's only a short postganglionic fibers. It can be where the ganglia are close to or even inside the target organs. In contrast, the postganglionic sympathetic neurons are thin and non-myelinated, slow conducting. An exception is the innervation of the adrenal medulla. The adrenal medulla receives myelinated, rapidly conducting fibers. There is no postganglionic innervation. Instead, you have secretion of adrenaline into the bloodstream. This idea of rapid myelinated innervation kind of makes sense in terms of adrenaline being an emergency hormone. Above the neck, there's a central autonomic network that's been described, where especially centers in the brainstem lead to the sympathetic preganglionic neurons in the intermediolateral columns of the spinal cord. We're going to be coming back to this later. Here's a kind of a close-up of what's happening at the level of the medulla. The baroreceptor afferent traffic, all baroreceptor afferent traffic. First synapses in the nucleus of the solitary tract, and then from the point of view of the sympathetic outflow, there's a kind of an indirect pathway from the NTS to the caudal ventrolateral medulla, then rostral ventrolateral medulla, and then sympathetic, and then descending pathway to the sympathetic preganglionic neurons. The NTS also is involved with baroreflex regulation of heart rate. That is by way of the nucleus ambiguus, and then the vagus nerve, the 10th cranial nerve. You can see that the baroreflex arcs are negative feedback loops. There's a single negative sign in the loop. That means that the level of the blood pressure or level of the heart rate will reach a steady state value, something that we'll come back to later. This is kind of an overview of cardiovascular innervation by the vagus on the one hand and the sympathetic nervous system on the other. You can see that there's both vagal and sympathetic innervation of the left ventricular myocardium. It used to be thought that the vagus didn't affect left ventricular myocardial function, but that idea was cast aside a generation ago. Vagal stimulation inhibits myocardial contractility. And of course, sympathetic stimulation augments that contractility. In terms of how the autonomic nervous system works, it's pretty straightforward. It works by way of chemical messengers. But the important take-home about this is negative feedback regulation. I like to use the analogy of a thermostat that regulates the inside temperature of the house. Without this thermostat and a negative feedback loop, when the temperature goes down on the outside, the temperature goes down on the inside. But when you have a thermostatic system and a negative feedback loop, then when there's information that reaches the thermostat, this has an effect on, in this case, the activity of the furnace, and the inside temperature will reach a steady state, shown here. It may not be the steady state that was set, but it's a steady state. This kind of model, based on what are called homeostats, is probably overly simplistic. No one has ever identified a homeostat, physiological homeostat, whether a thermostat or a glucostat or an osmostat, an oxystat. The homeostat is more of a kind of a metaphor for what is really going on, which is a very complex set of input-output relationships. The net effect may be give the appearance of a homeostatic comparator. No one has ever identified an actual homeostatic comparator. One advantage of having this idea of a homeostat is it's easy to define stress. Stress is a situation where there's a discrepancy, a sense discrepancy between the afferent information and some algorithm for responding, and the discrepancy is what drives changes in the effector. Although Cannon taught that the sympathico-adrenal system functions as a unit in emergencies, if you actually measure adrenaline and norepinephrine responses in different stress situations, you see that the relationship between adrenaline and norepinephrine responses is there, but there are some exceptions. For instance, when you go out in the cold, there's a substantial norepinephrine response, but there's no adrenaline response. On the other hand, even the smallest amount of hypoglycemia results in a very substantial adrenaline response and a small norepinephrine response. In contrast, there's a very tight relationship between adrenaline responses and responses of the pituitary adrenocortical system. So adrenaline and ACTH responses are tightly correlated across these stressors. What are dysautonomias? We already talked about the old man shoveling snow. This shows why, in the setting of an independent pathologic state, a coronary artery disease, shoveling snow in an old man would be potentially a lethal stressor. First, the person is standing up, and by way of the barostat, sympathetic noradrenergic outflow is increased. Second, it's cold, and as I showed you, there's a profound stimulation of the sympathetic noradrenergic system with cold. Usually, this is happening in the morning, and there's a circadian rhythm in catecholaminergic activity, and sympathetic and adrenergic outflows are highest in the morning. The person, of course, is exercising, especially with the isometric exercise. That has its positive effects on sympathetic and adrenomyelia outflows. And at least if you live around where we do in Maryland, there's a substantial amount of distress when we have to shovel snow in the morning, and that has effects as well. All of these combine to increase myocardial oxygen consumption, and in the setting of coronary artery disease, that can be lethal. But in general, there are 4 types of dysautonomia where there's an abnormality of the autonomic nervous system itself. And it's divided up in terms of whether it's acute or chronic, and whether there's stimulation or failure. Obviously, this is an oversimplification, but at least it provides a kind of a framework for moving beyond the simple idea of the autonomic nervous system that's either normal or not. We already talked about the Dysautonomias universe, and we're going to be focusing, because of the issues with Chiari malformation, on these overlapping syndromes in adults. What are the tests that are done to evaluate the autonomic nervous system, and what parts of the autonomic nervous system are being evaluated? By far, the most important autonomic function test is the autonomic history. And it's just unfortunate in our country that there's so little reimbursement for the time and effort of obtaining an autonomic history. Basically, what you want to look for is the chief complaint, the history of the present illness, or HPI, and an autonomic review of systems. The chief complaint, as you probably know, is a description in a few words or sentence about what the main problem is that's bringing the patient to the encounter. It sounds kind of Mickey Mouse, but I can tell you about an old lady who came to me for what was thought to be pure autonomic failure. But when asked what her chief complaint was, instead of saying it was orthostatic dizziness or an inability to tolerate standing up, something like that, instead it was that she couldn't make spit. Well, you remember saliva production, watery saliva production is a parasympathetic cholinergic function, and this would not, and so inability to make spit wouldn't be a sign of pure autonomic failure. One thing led to another, and it turned out that she didn't have pure autonomic failure. Instead, she had a pan-dysautonomia, and this was the first described case of autoimmune autonomic ganglionopathy. So chief complaint can be extremely informative. I begin the history of the present illness with the question, when was the last time you felt completely healthy? And I'm expecting one of three types of answer. One is I was healthy until, and the person remembers the date or the situation where things went bad. Or the person says, I've never been healthy. I've always been sick. Or the person says, I really can't answer that because it's such a gradual process. And these are important distinctions that will lead you towards different types of dysautonomias. In the autonomic review of systems, I tried to cover the 5 components that we discussed earlier. I asked, for instance, who does your shopping? And if the answer, and what I'm looking for is, well, not me, because I can't tolerate standing up. And then we pursue the line of questioning, moving towards a failure of the sympathetic noradrenergic system. In response to the question, do you sweat like other people? What I'm looking for is something like, well, I can't sweat at all, and this is something new, and that would be a sign of involvement of the sympathetic cholinergic system. Do you make spit like other people, or have you noticed problems with urination or bowel movements? These are, by and large, parasympathetic cholinergic functions. Sexual function is important, especially in evaluating the patient who may have pure autonomic failure or multiple system atrophy. In my experience, essentially all men with multiple system atrophy have erectile dysfunction as the first symptom that would lead to eventually a diagnosis of MSA. So the autonomic history is really, really important. I include this coat hanger because of the coat hanger sign. It's not something that is part of the usual medical history taking, but can be important in evaluating orthostatic hypotension or orthostatic intolerance, because this is a type of pain, kind of a Charlie horse feeling in the back of the neck, or upper shoulders in a coat hanger distribution. That's orthostatic. It occurs when the person is upright, and it goes away when the person is lying down. The way I explain the coat hanger phenomenon is in terms of ischemia and lactic acid production in muscles that are anti-gravity muscles. They're that are holding the neck up all the time, so that they're always using up oxygen. If you have a orthostatic lack of perfusion of those muscles, then it hurts, and that produces the coat hanger sign. I'm sure you've already come across these evaluations of joint hypermobility and hyperextension, and I'm not going to go into them any further. In terms of autonomic function testing that would be done in an autonomic laboratory, I think that the most important test is to track the beat-to-beat blood pressure when the person performs a Valsalva maneuver. In a Valsalva maneuver, the blood pressure changes in 4 characteristic phases. In the first phase, as soon as the person starts to blow against the resistance, blood is kind of squeezed out of the chest. It goes down the arms. The blood pressure goes up a little bit. This doesn't have anything to do with refluxes. It's a mechanical thing. But then as the person continues to blow against the resistance, there's less blood coming up to the heart. The heart pumps out less blood. The brain picks up on that immediately. Where's my blood? This causes a reflex to occur where the sympathetic noradrenergic system is activated. Norepinephrine, which you'll recall is the chemical messenger of the sympathetic nervous system, is released. It binds to its receptors in the heart and in blood vessel walls, and the blood vessels constrict. Because the blood vessels constrict, even though the stroke volume is still low, the blood pressure tends to increase at the end of phase 2. Then the person relaxes. Momentarily, the blood pressure falls. That's phase 3. And that doesn't really have anything to do with reflexes. It's like a mirror image of what happened in phase 1. Then finally, in phase 4, the person is just lying there, and there's no impediment to blood getting back to the heart. The heart pumps the blood, but it pumps the blood into this reflexively constricted vasculature. Because of that, the blood pressure overshoots, and that's what happens in phase 4. Naturally, as the blood pressure is going down, the heart rate goes up. In phase 2 of the Valsalva maneuver, when the blood pressure overshoots, and in phase 4, the heart rate rapidly comes down. In somebody who has failure of the baroreflex arc, whether it's because the information isn't getting to the brain, or the brain doesn't care because there's a brain disease, or the autonomic nerves are gone, or norepinephrine isn't released, or the receptors are blocked, you get essentially the same abnormal pattern. It looks like this. Here in phase 2, the blood pressure goes down progressively because the person can't tighten the blood vessels. And in phase 4, the blood pressure slowly comes up to baseline, but it doesn't overshoot, again, because the person didn't reflexively tighten blood vessels. Usually, but not always, this abnormal pattern is associated with blunting of the heart rate response, even though the blood pressure decrease is larger than normal. And that would point to baroreflex cardiovagal failure. So tracking the blood pressure and heart rate responses to the Valsalva maneuver provides, I think, very important information about the sympathetic noradrenergic system, the parasympathetic cholinergic system, and the baroreflex. The second type of autonomic testing, which you're, I'm sure, well aware of, is tilt table testing. In general, there are 2 types of tilt table testing. One is to assess whether the person is reflexively tightening blood vessels like the person is supposed to. And the second is for provocative tilt table testing to see if you can elicit neurally mediated hypotension or excessive tachycardia or syncope. Here's an example of orthostatic hypotension that's induced by tilt. You see a progressive fall in blood pressure, and there's really no reason to pursue this to the point of loss of consciousness. We define orthostatic hypotension as a fall in systolic pressure of at least 20 millimeters of mercury, or a fall of diastolic pressure of at least 10 millimeters of mercury by 3 minutes of being tilted from a supine to an upright position. I think I'm going to skip this. This is a measure of blood volume, which probably isn't that relevant to Chiari. I want to get into neurochemistry because this can be very informative. As you see from this slide, it's also kind of complex. When you measure norepinephrine levels as an index of the reflexive increase in sympathetic outflow, such as when a person is tilted, the plasma norepinephrine is determined in a very complex way. Most of norepinephrine that's released from sympathetic nerves gets taken back up. And the norepinephrine in the cytoplasm in general is recycled back into the vesicles. But a small amount of norepinephrine is deaminated by monoamine oxidase, eventually to form this chemical DHPG. DHPG is important, and I'm going to take a closer look at that. DHPG mainly reflects the stores of norepinephrine in the sympathetic nerves. There's a passive leakage process and an active reuptake process. And this is the main determinant of norepinephrine turnover. So DHPG has two sources. In under resting conditions, it's mainly coming from the leakage of norepinephrine from the vesicles. If you have sympathetic denervation or a decreased population of vesicles, then DHPG is going to be decreased. It also comes to some extent from the reuptake of released norepinephrine. If a person, for instance, had a problem with the norepinephrine transporter, then during an evoked increase in norepinephrine release, there would be more delivery of norepinephrine to the plasma, but it wouldn't be matched by an increase in DHPG. It would be a clue as to where the problem is. It may not be a matter of excessive sympathetic outflow causing the high norepinephrine, rather a problem with reuptake of norepinephrine. Another, I think, up-and-coming autonomic test is skin biopsies, and these beautiful pictures from the Harvard group led by Chris Gibbons and Roy Freeman illustrate the complex innervation of sweat glands and also the innervation of erector pili muscles. These are little muscles that cause your hair to bristle when you go out into the cold, let's say. Erector pili muscle is important because it receives pure sympathetic noradrenergic innervation. So in somebody who you think has autonomic failure from denervation, you would expect to see a lack of innervation of erector pili muscle. I'm going to talk a little bit about two specific forms of dysautonomia because they've been brought up so often with respect to Chiari malformation. One is chronic orthostatic intolerance, the postural tachycardia syndrome, frequent episodes of neurocardiogenic syncope, and chronic fatigue syndrome overlap. Here is, I think, a very illustrative a case of what happened to a patient who had fainting after about 40 minutes of head-up tilt. If you look at the blood pressure in yellow here, the mean arterial pressure fell right about there before the syncope. But you can see there were things that were going on before the fall in blood pressure. What were they? First, the forearm vascular resistance normally goes up and then it stays up. But in this person, you see the forearm vascular resistance decreased progressively as the tilt went on. And right here, about 10 or 15 minutes before the actual syncope, and several minutes before the fall in blood pressure, you see that the forearm vascular resistance went below baseline. As a mirror image, you see what happened to this is arterial plasma. You see the increase in adrenaline. Mirror image. I think that's because adrenaline relaxes the vascular smooth muscle and is responsible to a large extent for the fall in forearm vascular resistance. You can also see that norepinephrine here increased at first proportionately equally to adrenaline, but then beginning about here, there's a discrepancy. The adrenaline is still going up. Norepinephrine is not going up as rapidly or as much. It's a phenomenon that I call sympatho-adrenal imbalance. And as you see here, it precedes syncope, tilt-induced syncope. Here's another example showing the increase, really dramatic increase in adrenaline. You see the fall in forearm vascular resistance. We also see here something that's not really commonly monitored, but I think should be, and that's the skin electrical conductance. It's a measure of sweating. And people who are going to faint often sweat long before they faint. So these are signs of a pre-syncopal situation. And here's a summary picture of sympatho-adrenal imbalance in people who have positive tilt table tests. Here's kind of a simplistic idea about what's going on that causes the syncope. When a person is tilted, ordinarily the heart gets smaller, but there's peripheral vasoconstriction, and there's a maintenance of blood flow to the brain. Somebody who's going to faint, there's a decrease in forearm vascular resistance. I think adrenaline plays a big role here. And then so the blood is effectively shunted this way at the expense of perfusion of the brain. I think that's what causes the fainting. The main symptom of POTS is chronic fatigue. And I don't understand exactly why having excessive orthostatic tachycardia would produce fatigue. To me, the key to postural tachycardia syndrome is not the OT, it's the S. It's a syndrome, and it involves a variety of symptoms, including brain fog, GI issues that are mainly from upper GI motility problems, gastroparesis, nausea, abdominal pain. Chronic pain syndromes, as we'll see later on, delayed orthostatic hypotension, sleep abnormalities, heat intolerance. This is the S of POTS. When we formally studied the frequencies of these symptoms, you can see they're extremely frequent in POTS. Orthostatic intolerance, lightheadedness, fatigue, syncope, headache, and impaired concentration. What causes excessive orthostatic tachycardia? There's a large listing, and different researchers have different ways of kind of categorizing, I think, in terms of primary or secondary, especially secondary. secondary meaning that the orthostatic tachycardia actually reflects release of the sympathetic noradrenergic system from baroreflex restraint. And that could be because of hypovolemia, for instance. And if there's low central blood volume, there are a variety of explanations for this: excessive venous pooling, extravasation, dehydration, etc. If there is no decrease in central blood volume, you could still have a secondary problem, for instance, neuropathic POTS, where there's thought to be loss of sympathetic nerves in peripheral vascular beds and preservation of cardiac sympathetic outflow, and you end up with a secondary increase in cardiac sympathetic outflow. Primary causes of POTS, I think, are much more unusual. We already talked about net deficiency. Here's an example of POTS with syncope. You can see this large increase in heart rate, when the person actually loses consciousness, the heart rate falls, but it doesn't go down to what you would call bradycardia. It just goes down towards baseline. You can also see the blood pressure is, at least in this patient, remarkably variable when the person is tilted up, and I wish I knew why. I think it has something to do with the mechanism of the syncope. Many years ago, we formally looked at how much norepinephrine is released into the venous drainage of the heart in different different forms of dysautonomia. And you see in POTS, there is a fairly substantial increase in a release of norepinephrine, consistent with elevated sympathetic cardiac outflow, even when the person is supine rest. A second type of relevant dysautonomia besides the postural tachycardia syndrome is arterial baroreflex failure. Years ago, a fellow working with me, Yoni Sharabi, reported in people who have reported people who have baroreflex failure because of a remote history of irradiation of the neck, so that the blood vessels become encased in a rigidified carotid artery. Here's an example. I'm going to skip the portion about treatment of these conditions and get to the take-homes, and then to a particular case of Chiari that was treated neurosurgically at the NIH, and we did before and after the autonomic testing. First, dysautonomias are hard. The autonomic nervous system isn't one thing. POTS, syncope, and chronic fatigue syndrome overlap. The key to POTS is not the OT, but the S. And chronic orthostatic intolerance and orthostatic hypotension can reflect arterial baroreflex failure. But what I want to close with is a particular case of a patient who had a Chiari that was where the person was operated on at the NIH. And here you can see the Valsalva maneuver and you see the normal increase in blood pressure in phase 2, the overshoot in phase 4, a large increase in heart rate here. This person didn't have baroreflex failure. She also didn't have POTS, but she was miserable. And she had dramatic orthostatic hypotension that was delayed. And let's see, here we are. So if you look at the systolic pressure, you see there's an obvious orthostatic hypotension. It's delayed. Post-operatively, you see she had no orthostatic hypotension. she felt much better. Her Valsalva maneuver post-operatively didn't show. It showed a kind of a square wave phenomenon, which I don't have time to go into. When it comes to her catechals, also very interesting. You see, her norepinephrine was on the low side. It didn't increase like it was supposed to. During tilting, she had a progressive increase in adrenaline. And when we looked post, now you see there isn't this sympatho-adrenal imbalance. The norepinephrine goes up nicely with the tilting. I don't have a unitary explanation for the mechanism of the abnormality or why it improved, but I think you get a flavor for the types of testing that could be done that might be able to elucidate why there have been cases of Chiari where orthostatic hypotension was reversed or eliminated by the surgery. All right, that's about as far as I want to go, and I want to thank you for your attention, and I hope you. And I'll look forward to getting your questions, I guess, emailed to me.